We will begin by talking about quality indicators in laboratory medicine. So what is quality? Mario Pabani, in his article in the Clinical Biochemist Reviews, said, "Quality in laboratory medicine should be defined as the guarantee that each and every step in the total testing process is correctly performed, thus ensuring valuable decision-making and effective patient care." And likewise, Callum Fraser, in his book, Biological Variation from Principles to Practice, said, "The quality of tests performed in laboratory medicine must allow our clinicians to practice good medicine." So what is the role of the medical laboratory in this? The impact of laboratory testing in patient care contributes to greater than 60% of the medical decisions. The role of the medical laboratory is to communicate findings in a meaningful way for patient care, to provide clinical information and clarification to the clinician, to perform relevant and useful tests, to provide urgent findings, to participate in the interpretation of tests, and to be part of the medical team. So what are the steps that we take to producing a laboratory result? There's ordering, collection, identification, transportation, separation, preparation, analysis, reporting, and the action. And this we call the total testing process. And you can see it in this diagram where we have, starting with the patient and the doctor, going through the requisition, phlebotomy and transport is the pre-analytical phase around here. Then we go to the analytical phase where we actually run the analysis, review the QC and validate the results. And then the post-analytical where we're reporting the results, viewing the results, they interpreted and they go back to the doctor and the patient. All aspects of this process will affect quality: the pre-analytical, the analytical, and the post-analytical. So by pre-analytical, we mean all steps before the testing is performed. Analytical, the actual testing. Post-analytical, after the testing, and getting the result back to the doctor. And errors can occur in any part of this process. So in the pre-analytical area, our errors are running at greater than 50%. In the analytical area, only running about 20%. And in the post-analytical, running at about 30%. These are from surveys done by Bonini and Plaboni and colleagues. But in a survey done in another country, it shows the same kind of pattern. So this is a survey done by Pravin Gwali from Nepal, and I use it with his permission. So in Nepal, they found 60% of pre-analytical errors, 23% analytical errors, and 16% post-analytical errors. Analytical quality. In laboratories, we have concentrated on analytical quality. We've made improvements to our instrumentation, to our reagent quality, in terms of standardisation, and in terms of information technology. We have quality checks, internal quality control and external quality assurance. We monitor our laboratory processes, and this is one of the big advantages of being accredited to ISO 15189. In the last 10 years, there has been a 10 times reduction in the analytical error rate. But what about the pre- and post-analytical phases? Pre-analytical can actually be divided into two different parts, pre-pre and pre. So pre-analytical are the steps the laboratory may not have control over. For example, test requesting, patient and sample identification, and sample collection. Pre-analytical are those steps required to prepare the sample for analysis. For example, centrifugation, aliquoting, and sorting, and these are usually done within the laboratory. In the post-analytical phase, likewise, this can be divided into post-analytical, those steps required to prepare and send the result, or post-analytical, steps the laboratory may not have control over, for example, result interpretation and the ensuing action. There is a higher incidence, as we've seen, of errors in the pre-pre and the post-post phases. This is an example of a pre-pre analytical incident. And this example comes from Professor Jeffrey Kellerman, who some of you may know. He comes to Vietnam frequently to conduct education courses. There was a patient in a hospital ward who had some pathology testing done, and it showed a very high creatinine with a previous sample collected 12 hours previously, which had been normal, and a very high potassium. So the patient was given anti-potassium therapy. Then there was a visit to the ward, and it was discovered that the patient in the next bed was the one who had a history of a high creatinine and potassium. The identity of the patient had not been thoroughly checked. So this pre-analytical error had a significant effect on the clinical management of the patient. Once the error was discovered, the patient had to be given potassium drip for 2 days to ensure that they got back to an adequate potassium level. Let's now think generally in terms of quality improvement. If you want to do some quality improvement in your laboratory, you need to, first of all, identify an error, then evaluate the process, improve the process, and monitor the process. So to identify and evaluate, you can use tools known as quality indicators. They enable the user to quantify the quality of a selected aspect of patient care by comparing it with a criterion. And the identification of reliable quality indicators is a crucial step. So critical aspects of patient care have been identified by the Institute of Medicine, and these include patient safety, effectiveness, equity, patient-centeredness, timeliness, and efficiency. The International Federation of Clinical Chemistry, or the IFCC, has formed a working group on laboratory errors and patient safety. And I've given the website there, and you can go to that and look up some more information on them. But their aim is to stimulate studies on errors in laboratory medicine, to collect data, and then to recommend strategies and procedures to improve patient safety. And to do this, they've developed a set of quality indicators. So I'm going to go through some of the quality indicators that the IFCC have developed. And in the pre-analytical area, there are 16 quality indicators, starting with test ordering, looking at the appropriateness of the test request. First one is the percentage of requests with the clinical question. Second one is the percentage of the number of appropriate tests for that clinical question. Then on formulation and input of the request, there's looking at the examination requisition. So that's the number of requests without physician's identification or unintelligible requests. And I'm sure we've all seen some of these in our laboratories. In terms of the identification, there's the number of requests with erroneous patient identification or erroneous physician identification, or errors concerning the test input. Going on to identification, collection, handling and transport of samples, there's the number of samples that have been lost or not received, the number of samples collected in inappropriate containers or hemolyzed, clotted, with insufficient volume, with inadequate sample anticoagulant ratio, damaged in transport, improperly labelled, or improperly stored. Then we have our analytical quality tools, and these are ones that we're very familiar with: internal quality control and external quality assurance. So what is internal quality control? It's the set of procedures designed to monitor the test method and the results to ensure the test system is performing correctly. Testing of a defined control material and confirmation that the results obtained are within the previously established limits of acceptability. They're performed prior to the release of patient results, and the fundamental principle here is that errors detected by means of a control material will exactly mirror errors occurring with patient specimens. So errors need to be corrected immediately, and patient results not released until errors have been fixed. Now turning to external quality assurance. This is where I come in. I run an external quality assurance program. So this is testing of unknown samples which have been sent by an external organisation, such as the RCPA QAP or Biorad or Randox or your Vietnamese EQAs. So the aim is to objectively assess the accuracy and imprecision of the results obtained. All the labs in the program test an identical sample with an unknown value. The samples are treated and tested in the same manner as you would a patient sample. The results are returned to the EQA organiser, who evaluates the results from all participating labs and returns a report to the laboratory. The laboratory's results should then be within the set of acceptability criteria. And this is an example of an EQA report. So this is one for sodium. 2 samples have been run, and you can see all the results of the participants. There's a breakdown of the methods, and you can see the laboratory's performance over time. We turn now to post-analytical quality tools. The quality indicators for these on reporting results are reports delivered outside the specified time, that's our turnaround time, the number of critical values that have been communicated, the average time to communicate those critical values, the number of interpretive comments provided that impacted positively on patients' outcomes, and the number of guidelines issued in cooperation with clinicians per year. Let's now keep on with our quality improvement process and talk about how to improve the process. So, improvement in the pre-analytical phase. It's important to collect all the relevant information about an incident, investigate the cause, and take action to prevent a reoccurrence in order to protect patient safety. So, for example, sample misidentification. 25% of errors in misidentification are due to unlabelled samples, 26% due to a mismatch of identifiers, 18% due to transfusion misidentifications. How can this process be improved? One way of doing this is an example. This is actually a poster that is designed to go up in the wall where the blood collection is taking place. And it uses the acronym TEST, where T is talk to the patient, ask the patient to state their full name and date of birth. E, ensure a match, ensure the patient's identification matches the pathology request and identification band if they have one. Sample type, check the sample type required for each test requested. T for tubes labelled, correctly label sample tubes at the patient's side with full name, date of birth and a unique medical record number if possible. So that's just a simple process, a simple poster that can go up in the patient collection area that will remind people of the critical areas so that the number of pre-analytical errors can be reduced. Back to our quality improvement. Let's talk about monitoring the process. So to monitor, we can use an external quality assurance program as a tool and to monitor and control the pre-analytical, analytical and post-analytical activities. This allows the laboratory to identify risks that lead to errors resulting in patient harm, to benchmark their laboratory against other laboratories, to identify and design practices that eliminate medical errors, and to share information and education on clinical and laboratory teams on practices that reduce or prevent errors, and then to monitor and evaluate the improvement in activities. And I'm going to talk about a couple of different monitoring external quality assurance programs. The one I've talked about already, the IFCC one, using those 25 quality indicators that we've talked about on their website, and also then I'll talk about the RCPA quality assurance programs, and we have two, one that's called KIMS, which stands for Key Incident Monitoring and Management Systems, which looks at pre- and post-analytical errors, and another one which is a post-analytical clinical comments program that is an educational program. So KIMS collects data on only key quality indicators, not all of those ones that the IFCC uses. Specifically, the ones that have been selected are the major ones. In the pre-analytical error, it's sample misidentification and sample rejection. In the post-analytical, it's where the report has been retracted due to an error and where the report has been sent to the wrong doctor. So this is an example of one of the results. So the data is collected over 4 different collection periods of the year. This is pre-analytical identification problems, and I don't expect you to be able to read this, but the pink ones are the major problems that have been identified. Unlabelled samples accounts for about 25% of errors. Any mismatch or discrepancy of identifiers accounts for about 26 to 27% of errors, and transfusion misidentifications of about 17 to 18% of errors. And then overall, when we look at the pre-analytical and the post-analytical combined, again, over the total number of accessions in the laboratories who are enrolled in this, so this is where lots of laboratories come and put their data together, and we're looking about a 1.5% error rate. So these laboratories at this stage are principally Australasian laboratories. Another post-analytical external quality assurance program is the patient report comments program. Now, this is interpretive comments on pathology results, and it's for individuals who add comments to reports or answer phone calls. So in Australasia, pathologists, registrars, scientists or other laboratory staff may put comments on abnormal results or will answer phone calls from the doctor asking what this set of results means. This is an educational self-assessment program and is designed for continuing professional development. So this is an example of the report that we send out. So this case has been sent to all the participants. It's one where we have a 45-year-old male who has gone to see his general practitioner. He is a chronic alcoholic. We have a high amylase result and a normal lipase result with some additional information on other tests, which just shows the gamma GT has been elevated. The laboratory puts their comment into here, and we assess the comment by breaking down the key words, and these are some of the key words which you can't read. I'll show you them in a minute. We then we have an expert panel that designs a suggested comment. So this is the one that is the recommended comment and gives a rationale and reference on the particular case. And on the back of this report, we have the key words. So these have been classified as preferred, less relevant, not supported, or there may be some misleading keywords. So the idea of this program is that you can learn to interpret the results and put the correct comment on a patient report. We've looked at the total testing process. We've looked at the errors. What do you do if you want, what first steps do you do if you want to improve the quality of your laboratory? The first is to begin to collect your laboratory data. Then look for opportunities for quality improvement. Begin targeted continuous improvement activities aimed to reduce the risk of errors in clinical practice. But remember, preventing error relies on identifying deficiencies in processes, not people. And the other thing that we always need to remember is it's all about patient safety. I've given you some references for you to follow up in the book, and I leave you with our picture of one of the longest rivers we have in Australia. That's the Murray River. Thank you.